So I would like to talk about the architecture of isolation and how within the escape room that I've been running for about a year and a half now, that I've used or leveraged Ludic design to help my students improve their clinical reasoning when it comes to care of the elderly. So I'm going to take you on a little gamified tour of our escape room. So really, to put this into context, our focus was a cohort of 14 postgraduate nurses and paramedics at the start of their minor illness module at the beginning of last year, 2025. And in the high pressure world of urgent and emergency care, these clinicians are managing geriatric patients or the older person who rarely present with a textbook case. Instead, they face complex, unspecified and often overlapping conditions. Historically, this module even has relied on traditional lectures, which we felt limited deep engagement. Even standard simulations didn't quite hit the mark, as they felt too much like a rehearsal for the summative OSCE or their clinical examinations, rather than a space for true exploration and knowledge building. We needed something different, and that's why we developed Mabel's Escape Room, or as we call it, Escaping to Empathy. But it's a novel, immersive, problem-based simulation designed to bridge that critical gap between theory and the advanced clinical assessment required for elderly care. Further to that, social isolation and addressing psychological needs was something our cohorts had never considered exploring in any depth. And this is a growing problem and a significant risk for deterioration and admission in the elderly person. So, first of all, we began with designing an authentic scenario, built with subject matter experts in co-production. Because constructivist approaches work best when learning is situated in a realistic problem space rather than presented as abstract content, the escape room opens with a believable clinical or narrative concept so the learners feel that they are entering a problem to be solved, not just completing a task on a checklist. The next box is the information gap. This is important because curiosity is triggered when learners recognize a gap between what they know and what they need to know, and that uncertainty motivates them to search for answers. That leads into fragmented evidence. So instead of giving them one complete explanation, I used partial props, such as diary fragments, voicemail clips, and scattered clues, so they had to work with incomplete information. And that design choice was deliberate, because constructivism treats challenge, ambiguity, and incompleteness as productive conditions for learning, rather than problems to remove immediately. From there, learners move into narrative construction. They are not simply collecting the answers, but they are assembling those fragments into a coherent account of what's happened to Mabel, which means they are actively building meaning from evidence. And more importantly, as those within healthcare will know, they're keeping the patient at the heart of everything they do. The next stage is collaborative sense-making. This is about discussion, disagreement, negotiation between players that are not side effects of the activity. They are central to how the understanding is formed. And finally, the process ends with a reflective debrief, which is where the experience is made explicit, where learners test what they had thought, compare interpretations, and connect the game mechanics back to the intended educational concepts. As we know in simulation, reflection and debrief is what helps turn activity into durable learning. So this side focuses on from the patient as an individual to the environment as a source of learning. So rather than treating the room as just simply background scenery or something to look at, I wanted learners to read it semiotically, so looking for the signs. So I filled the space with signs that suggest something about the person's life, routines, and her possible decline. The elderly woman is present, Mabel, but she is not the only source of information. The most important feature is the table and the 3 floating props you can see there. These invite interpretation rather than giving a direct answer, and is a really useful tool for building on in the debrief. Environmental storytelling works exactly in this way. The setting and its objects become part of the narrative. The knitting basket, for example, suggests that a former hobby, routine, or identity implies occupation and familiarity, but in this context, it may also suggest an activity that has been interrupted or abandoned, particularly when you build up these fragmented clues. The book works in a similar way. It may signal leisure, solitude, cognition, or routine, but also raises the question of whether these ordinary habits are still being maintained. Signs do not carry fixed meanings on their own. They gain meaning from their relation to the wider scene. The calendar with the question mark introduces uncertainty. It points to disrupted time, missed contacts with family, friends, and forgotten appointments, or an unclear daily structure, which encourages the learner to ask what has changed in Mabel's life. What matters is that none of these props prove social isolation by itself. Instead, they act as behavioural clues or stigmata within the domestic environment, prompting learners to build an interpretation about isolation, abandonment of hobbies, and a loss of routine, and the reasons for that might be within this case. Simply, they are not just observing a patient, they are reading a room. They are treating the room as data, which turns the domestic space into part of the clinical reasoning process, essential to real-life practice. So these are part of my Ludic assets that I have built on, and as you can see, it's the complete opposite of what Celine was describing yesterday in a very immersive space. So this is about as low-tech as you could possibly get. Me and my colleague behind a UV light sign, and you can see her knitting basket on the floor underneath the table there. We've got a News 2 puzzle, which shows her part of her physical deterioration. We have a book, which I turned into a book safe to hide keys, and then her social prescribing and psychological readiness clue box there, ready to go as part of the next steps. So how do we connect the dots? So the patient needs, there is an identifying or a theme running throughout of loneliness. And the jigsaw puzzle are around social prescribing. Each fitted piece represented a clinically reasoned connection between an unmet need and a community support pathway. That puzzle assembly externalizes the reasoning, helps them physically map scattered patient needs into a coherent support plan, rather than ending with some generic discharge statement that is not personal or holistic. Connecting the dots therefore becomes referral logic, and it builds awareness of the social prescribing and support available in the communities to the elder population. This builds system knowledge into a memorable, playable act of linkage and accountability. While the goal was clinical, the challenge was also logistical. To make Mabel's room work, we used Google Gemini as a co-designer in 4 key areas. Firstly, guiding the time frame to mirror the reality of a 1-hour complex falls encounter. We used it as a logic assistant to track our dependencies and swapped. If we swap clues, then the AI recalculated that flow to ensure that never broke, protecting the cognitive load and the pedagogical heart of this experience. Finally, rapid troubleshooting. But geriatric presentations at the heart of this are intentionally messy. There are multiple clues, competing risks, and environmental noise that mirror what they would ordinarily and authentically experience in practice, rather than a neat textbook sequencing. The AI-assisted tuning helped to calibrate the clue density, pacing, and challenge escalation so that the scenario felt pressured without tipping them into psychological stress and overload. The goal is to sustain a systemic train of thought, whilst the room itself competes for the attention, ambiguity, and emotional bandwidth we as escape room designers aim to hit. So the breakout is the spark. The diamond debrief that I used within this model converts playful momentum into safeguarding insight, professional accountability, and reflective reflaming. Debrief destabilizes the comfort of we solved it and redirects the attention to what remained unseen. The safeguarding risk, the neglect, the loneliness, the community vulnerability. Sometimes these factors are particularly hard to deal with, can hit emotionally and psychologically to those assessing or dealing with patients like this, and therefore facilitators can explicitly pivot from playful success to the ethical reality of the patient who still lives beyond the scenario. Who was invisible during the puzzle and what systems, assumptions, or omissions kept them invisible can also be discussed. But at the end of it, we broke out, and Mabel still has to go home. So my advice, if anyone is looking to do this, it is very much possible, and with great success, that my students have repeatedly rated this really highly, and also is an effective tool for learning. But I would encourage you to design for cognitive fidelity rather than technical realism, as it seems that, in this case at least, is what provided a significant proportion of the learning. Thank you very much for listening.
Perfect. So this talk is just to kind of talk through a method that we use to co-create an escape room using academics and students from lots of institutions, as you can see there. The origin of this, or kind of where it started, is myself and Aaron used to work together on a beautiful Caribbean island. And then for some reason we left that place. And COVID rolled along and we needed some way to virtually engage our students. So started using virtual escape rooms, and Aaron did the same. We got some students on board and we both created virtual escape room, and tested it out and wrote it up. And we were lucky enough to win a sort of a prize for these escape rooms in this paper. And as part of the prize, we had to present the work at a conference there in December. And in the conference, we basically said, we like escape rooms. Does anyone else like escape rooms? Do you want to be our friend, basically? And we had 5 lovely people contact us and say they're interested in virtual escape rooms as well. So we formed this little community of practice, and we decided we'd make an escape room. So to start, we made a little Microsoft team, and we had a 1-hour meeting just to help develop questions from the start. I did a little sort of a PowerPoint template for the meeting just to kind of structure things a little bit. So we voted on what topic we'd like the escape room to focus on. We picked up the platform we wanted to use, the type of escape room sequence, and then did the hard part, which is the brainstorming for different scenarios. And I was looking at this yesterday, and I thought it was very funny. This was one of the scenarios, a cruise ship doctor. So it was a bit pretentious for what's happening recently. But we settled on some sort of disaster in a zoo where lots of animals have attacked people, basically. I went through the different question types that we've used previously. So things like dingbats, normal multiple choice questions, crosswords, word searches, AI generated riddles, wordles, 2D images, 3D images, jigsaws, matching and ordering information is quite useful in anatomy, anagrams, and there's a few sound-based clues that you can use as well in anatomy for things like heart rate or heartbeat and so on. So we basically picked the question type that we were interested in to work on, and then we brainstormed some topics. So we wanted kind of high yield topics that were going to be relevant to students in all of the institutions that are included. And we basically then had a little quiet moment in our meeting for about 10 minutes where we each worked on one topic and one question type. So after the 10 minutes, then we kind of came together and went through the questions just to kind of, I suppose, do a bit of quality control and see how they might fit together. And this is just an example of a question development slide, or how the information would have been structured. So the topic and the question type, a sort of a scenario that it might fit into, some sort of clinical relevance, images that might be used within the question, and also an explanation, an answer and an explanation. It's because sometimes you may have to add things like clues and so on. So once all of those were created, I went away and started assembling the virtual escape room. So to do that, I basically just made a folder in Google Drive. I made a Google slide, which is the room. And this is, you might be able to guess, quite AI generated. I'll come to that in a wee second. And then also a Google form, which is where they will input their answers. I added any other Google Slides or Google Forms that are going to be part of the clues section for the escape room also into the folder, just so it's kind of easier to keep track of. So to start off with the room, if you will, there's quite a lot of issues with this picture, but I thought it sort of adds the charm of it a little bit. Some of the animals are very exotic looking. But that's basically a ChatGPT prompt where I basically put in each of the patients that I want to include, and give a little bit of information about them, and it generated the image. And I did this actually the first time. I didn't tweak it at all. I was happy enough with it. And then after that, I brought this into the Google slide and made it the background. So it's not clickable, it's just there on the background. So the next thing is you want something to link to the Google form. So I asked ChatGPT again to generate an image of an ambulance, thinking this doctor is arriving on scene in the ambulance, so he'll click there first, and that'll lead them to the Google form. They didn't all quite catch that on too quick, so I did add a tip to say start here, basically. So the next thing is to make it a bit, pressured, because it is a game. So I added a timer, and that's just simply done by inserting a video. It's a YouTube video. For some reason, there's lots of YouTube videos of timers. So that was easy enough to do, and that'll autoplay once they open the room for the first time. For the Google form itself, I'm probably preaching to the choir here. I'm sure everyone knows how to use Google Forms, but you can select your question type. You can make it required if you want them to answer it before they progress, and you can define your correct answers. So lots of different options for Google Forms. In terms of adding clues, I basically added a shape on top of the background and then made it transparent and then made it link to a clue. So that could be to a Google slide or a Google form, to a video, an image, a jigsaw, anything else. So an example, I've just put in a few example questions here. So this is one of them. This is a little boy. This is actually Aaron's question, I think. He's on the call. A little boy here, and his elbow's been twisted. And students click on the little boy and they'll get an image of an elbow, and they have to be able to identify which ligament has been affected here. And to do that, to link kind of a part of an image, I just drew a freeform shape in Google Slides and linked it to the Wordle. So the Wordle is done through mywordle.strivemath, which is very easy to use. And basically they have to figure it out to get the name of the ligament, which they put into the Google form. So that's the solution for that one. For just another example, actually I should mention this first, just if you're interested in doing it, when you're sharing the link, obviously it's a viewer link for the students. If you change the edit within the URL to preview, then you'll get a slightly more streamlined image rather than the image that has, the thumbnails and everything else. So that's a useful tip. Another example is a jigsaw. So this one was, this girl here has broken her wrist basically, and you click onto it and it links to a jigsaw. So this is through Jigsaw Planet. This is all free. All of this is free. They solve the jigsaw and they have to identify the name of the fracture. So it's a Colley's fracture, that's called. Another example is a crossword. So this is where they click onto this poor man that's getting mauled by question mark polar bear, perhaps. And this brings them to this image, which is an angiogram. They found this quite difficult, but they basically could click here, solve the crossword by typing, and then they had to identify the letters that are circled to put that into their answer, into their clue. Another example was this one, which was this poor man here. He's, I think, dislocated his shoulder, or he's a fracture, actually, sorry for this case. And they had to solve this dingbat that one of our group created. They found this quite tricky, so I did add a clue, and the clue basically links them to 3 types of fractures and 3 nerves commonly affected by those fractures. So if they were really struggling, it's basically one of 3 of those, so it shouldn't be too difficult. Okay, and the answer there is supracondylar, so if anyone got that, well done. Another example is an AI riddle. So this is where we have a newborn baby with an injury to some of its nerves in its neck. And basically, it's very simple to get ChatGPT to generate these type of riddles, which are useful, kind of looking at different aspects of the clinical syndrome. In terms of the pilot feedback on this, so we did test it with some Queen's students. So sent the link around to our first year students the week before their exam, which was this Wednesday past, and 22 of them completed it, mostly individually and 1 as a team. And then in terms of their perceptions of the escape room, so quite a lot of them agreed, or strongly agreed, I should say, that they found it fun, which was good. Bit of a mixed reaction in terms of whether it's too difficult, so maybe not too bad there. And then quite a lot of them agreed as well that it was clinically relevant. In terms of the time it took them to complete, I did allow 60 minutes, but on average it took them only 38. When we asked if it was useful for revision, they seemed to think it was. I was also curious if they would prefer it as an in-person activity or as a group activity, but that was a bit of a mixed bag as well. So I suppose perhaps it would work either way. So that was kind of the feedback from the students. We had some comment-based feedback as well. So in terms of what they might have found confusing, they don't know their birds. That became evident. So larks, I actually didn't know the lark either. So they found that a bit tricky. So that's why I added a clue for that. They didn't know where to start. So I added a little clue just saying click on the ambulance. And also added instructions in the first 2 questions to actually click on the patients. The angiogram did stump them, but that's just because it's a bit difficult. And in anatomy, unfortunately, we have like multiple names for everything. So when you're defining your correct answers, that can be a bit of a tricky one. And then one student did want us to let him progress, even if he didn't know the answer, which I thought would be a bit risky in case it reinforces the wrong information. In terms of what they found most valuable, let them identify some gaps in their knowledge and see the clinical relevance of things. And I like that comment as well, that they just liked it because it was something a bit different. So hopefully that's a very quick run through of our co-creation method. I really enjoyed it. It was great, meeting up with virtually with people that are quite interested in these things. And it was a very efficient way to get a virtual escape room off the ground. Helped kind of distribute the creative load, which can be the hardest part of these things, and see a wider range of perspectives and ideas. And now when we test this with all our students, it'll go out to 7 institutions, reaching lots of students. So it has maybe a greater potential for benefit. Okay, so I'll leave it there. Thanks very much for listening. And if there's any anatomists listening that want to join our group, feel free.
So yeah, this is my presentation. I'm a medical student right now at Cardiff University. I'm intercalating in emergency and pre-hospital medicine. And part of my project was the use of escape rooms in the emergency department and basically seeing whether we can use it to sort of teach our clinical and non-clinical skills. So why does this matter? Starting off with the emergency department, I'm sure if you guys have watched things like Casualty, you've seen sort of the chaos that you can see in the emergency department. It's very high pressured. There's a lot going on, a lot of decisions to make very quickly, and it can get quite messy and it can be difficult to make some of these decisions. To be able to ensure adequate patient care, you need to use a mixture of skills. Now, these include your clinical skills. These are sort of managing patients, recognition of things that are going wrong, knowing how to treat it, and also your non-clinical skills. These are things like your communication, your teamwork, your situational awareness, task management. These are things that aren't necessarily taught too well. So with our clinical skills, we do sort of focus on these definitely in the medical education and within the emergency department education system as well. However, we don't always teach the use of these skills under pressure. So with our current teaching methods, we have sort of lectures and tutorials. These are great for building knowledge. We use them all through medical school, and we continue to use them in the postgraduate education. And these sort of give people the knowledge of management and recognition of conditions. However, it doesn't necessarily recreate the pressure where this knowledge is used. This comes to sort of our simulation type teaching, where we have clinical scenarios that we can almost rehearse how we would recognize illness and manage these patients. However, sometimes these can be slightly unrealistic, and they're not necessarily always the best environment for people to actually showcase their skills. We found that people mentioned that simulation wasn't necessarily safe all the time, and with different roles that are assigned, it's quite easy to sort of step back and, take the back foot. Now, with medical escape rooms, we sort of wanted to see, well, of course, we know escape rooms are active, they are time limited, they allow you to sort of add a bit of fun and novelty to your learning experience. So we wanted to see whether we could sort of blend our clinical learning, our clinical decision making, with our non-clinical skill use. Currently, on medical escape rooms, the literature suggests that it is good for learning. We found that people have improved their knowledge, and it's been comparable to some of our traditional teaching methods, such as tutorials and lectures and simulation as well. People have found that sort of they're able to work better in a team using escape rooms as well. Now, for my project, I want to look at the emergency department specifically. I wanted to know whether we could combine some of the management of conditions that are seen in the emergency department with the skills required to manage them. And the project really looked at the blending of the two types of skills together rather than teaching them separately. So for our research, we had 37 participants. These were a mixture of medical students at different stages of training. So we had third years sort of new to the clinical environment. We had fourth years who were intercalating in emergency medicine as well, so are quite used to sort of that department. We have fifth years as well who are in their final year of medical education. We also had postgraduate trainees who work in ED. And we used the condition pediatric diabetic ketoacidosis, which is a complication of type 1 diabetes, sort of form our learning outcomes. What we did is that we had a questionnaire before that people completed. This looked at confidence, the confidence of managing certain parts of the DKA. Then we also had a questionnaire afterwards, and we looked at a change in that confidence. We also did a post-session debrief and a group interview where we were able to sort of look at some of the learning behaviors, the way that groups worked, and try and find any sort of weaknesses, things that we would need to change when we go on to do sort of further work with this with the study that we did. So in terms of our design, we had 3 zones. So we had a zonal design. The first zone is where we looked at the recognition of the DKA. The second zone was the initiation of fluids, which is part of the management. And the third zone was the initiation and monitoring of the incident, another important part of the management. Now, we picked these 3 zones based on things that were highlighted within the guidelines for effective management. The final zone was a time pressured zone. So the escape room itself had half an hour. And then that final zone was a further 3 minutes where we had extra noise, auditory stimuli to really increase the pressure felt by the participants. So as you can see in our first image here, this is how we set up the escape room. It was completely dark. Participants, as you can see, had to use torch lights to find clues, to put them all together. We had UV light as well to add to the novelty and add to the challenge of using it. Now, in order to create sort of a pressured environment, we had the sort of low-level lighting, the auditory stimuli, we had locked boxes and UV clues, so people had to be very engaged to actually get the learning out of it. Now, from our questionnaire, we found that all domains, we saw an increase in confidence of the management. So our largest increase was in the management of cerebral edema. This is a complication that you can get through the treatment of the DKA, and it's quite important to recognize and to be able to treat. The lowest increase was the increase in knowledge of escalation. So people were generally quite confident on this before. We also found with our non-technical skill use here that people thought they could use it more in the escape room compared to our traditional simulation. All these scores were based on a 5-point sort of Likert scale. So it was basically a 1 if they thought they couldn't use it, 5 if they thought it was really good. Now, in terms of a qualitative analysis, what we did as shown here, we started off with the group interviews and we got transcripts from those interviews, went through and produced codes for all of them. So basically anything that cropped up, we gave it a code and we put these codes into groups. Then from that, we developed the themes that we used for our research. Now this word cloud here shows us sort of all the codes that, well, not all of them, but most of the codes that came up, some of the things that were repeated multiple times. We see some of our non-technical skills there, like our leadership, teamwork, managing of cognitive load, communication, were quite high things up there. And what we did is that we focused on not just whether it was enjoyable, but what sort of behaviors were seen and what learning processes were seen. So some of the core themes. Our first core theme was that the pressure from the environment changed people's behavior and people's use of the skills. So with the darkness and the auditory stimuli, you had to be very clear. Some of the some of the communication strategies that are sort of taught in the emergency department of being sort of clear, closed loop communication. People had to do this to be able to get their points across. We also found for our second theme that the flattened hierarchy helped people to be able to use their non-technical skills, those non-clinical skills. People felt more comfortable sort of using teamwork, using leadership, being a bit more assertive. However, sometimes when you had larger groups, participation wasn't even. So although we found that like more people were involved, people who were tending to be a bit more quiet did also take a back foot. In terms of the knowledge development with our third core theme, we found that people develop knowledge through sort of active use of knowledge and collaborative learning. So people were learning from each other. They were able to sort of build knowledge rather than just being told, but it did rely on prior knowledge. So our interpretation is that the escape room worked as a consolidation tool, but it did require prior knowledge of management. So the conclusions is that we found confidence did increase, and we found that team behaviors became, well, it was the right environment to allow people to develop those team behaviors. And our active problem solving that was seen as supported the development of knowledge. Things we have to think about is that this was just about confidence rather than competence. So you would need more objective measures. We also found that obviously with larger groups, participation wasn't as even between people. And of course, when you're setting things like this up, we have to make sure that we are setting up in a way that allows people to actually use those skills and allows people to learn. So the bottom line is that could be useful adjunct in the emergency department, and we can combine our non-clinical skills with our clinical skills using the medical escape rooms. So thank you to my supervisor, Dr. Sarah Edwards, and to Dr. Zoe Morgan for supervising the project, Owen Crawford for sort of allowing me to use the facilities in the university, and all the participants who took part. And that's just an overview of the escape room I ran. Thank you.